Now, how early can we start ARNI in acute decompensated heart failure? Do we start it before discharge or during the first follow-up? And what are the precautions you need to take? The Pioneer HS trial, the study designed was that they examined 881 patients who were hospitalized for acute decompensated heart failure with ejection fraction less than 40%. The patients were stabilized while still hospitalized. The systolic blood pressure was more than 100 within the 6 hours, no increase in IV diuretics prior 6 hours, no IV vasodilators in the prior 6 hours, and no IV inotropes in prior 24 hours. This is very, very important. So, when we are starting a patient of ARNI, it should be justified that when you are comparing an ACE inhibitor or an ARNI, there is no doubt that you need to start ARNI, but when do you start it is the question for acute decompensated heart failure. So this recommendation is very important. So if a patient has a systolic blood pressure, which is approximately around, according to me, even 90-100 is fair enough. A patient who has stopped his inotropic support in the last 24 hours, not receiving any IV diuretic therapy, and also that the patient should not be on vasodilators in the last 6 hours. So these are the time when you should start initiating your ARNI, and this should be done prior to discharge. Why is that? The studies have found that there is a change in the NT-proBNP not within like a week or 2 weeks, but within the first 8 weeks after randomization. So when you have a patient just on an ACE inhibitor of enalapril, and as you compare it to an ARNI, you'll find that there is a dramatic change in the NT-proBNP over a period of 8 weeks from the baseline initiation, and this starts within the first week. So the benefits of starting ARNI should be taken as early as possible prior to the discharge. And also the second point, the cardiovascular death and rehospitalization for heart failure, the benefit starts immediately within the first week, as you see after randomization, and you'll see that the graphs completely vary and they diverge. The benefits are definitely weighed towards ARNI as compared to ACE inhibitors,